my name is Kayvon Karakuti and I'll be talking about pharmacologic management of intraoperative coagulopathy. My disclosures are listed here. I have had research support by Octapharma and I've been a consultant for Octapharma Instrumentation Laboratory and Bayer. As an overview, I'm going to mention that I'm going to primarily focus the talk on management of bleeding in cardiac surgery because there is simply a lot more evidence in this population. However, much of the content should be readily applicable to other settings of major bleeding. Specifically, I'll discuss tranexamic acid. I'll talk a little bit about platelet function and platelet transfusions. I'll talk about hypofibrinogenemia and its treatment, and then also on low coagulation factor levels and the treatment of that. First, I'm just going to start by going over what the guidelines say. Now, traditionally, North American guidelines have been quite different than those guidelines from Europe. However, more recently, they're kind of becoming more and more congruent. Here is a recent guideline published in ANA in 2019 by the Society of Cardiovascular Anesthesiologists in terms of management of bleeding, intraoperative bleeding in cardiac surgery patients. In this guideline, they recommend the application of transfusion algorithms that incorporate coagulation monitoring with point-of-care assays to guide hemostatic interventions. And they also, at the last point there, they mentioned that goal-directed therapy with coagulation factor concentrates, such as fibrinogen concentrate or PCCs, should be used because they may reduce transfusion-associated adverse events. Some comments on point-of-care based transfusion algorithms. One thing to keep in mind is that the algorithms are not always applicable. Specifically, for example, when you have catastrophic bleeding, you do not have time to even wait for point-of-care assays. So at in those situations, it might be best to revert to trauma-based management or ratio-based management of blood products and just transfuse 1:1:1 or 1:1:2, depending on the ratio of red cells to other coagulation factors. Second point is that just like any other laboratory assay, these assays are not always correct, and your clinical decision has to be based on what's happening with the patient. So if the patient's not bleeding, but the assays are abnormal, you're not going to be administering hemostatic agents. On the other hand, if the patient is bleeding and it's coagulopathic and the assays have missed it, then you should probably institute treatment based on the most likely defect. The cost of these assays are substantially more than standard coagulation assays. So we basically have to constantly show that there is value to conducting these assays by having a good QA or quality assurance process so that the institutions are aware that it's worth spending the additional money to have point-of-care based assays. And then the last point here is that the assays have to be, the algorithm has to be clinically feasible, in that clinicians should be able to look at it, incorporate it into practice without having to really think about it and having to learn a lot of new stuff. So the assays have to be informative yet easy to understand to the clinician. So the question becomes, how do you design a coagulation management algorithm that's simple? Because coagulation is very complex. Here is a very simplified version of the coagulation cascade. And even this, as you can see, is quite complex. So our strategy was to design an algorithm that focuses on the critical components of the coagulation cascade and the parts that we actually have treatments for. And if you look at the components of the coagulation cascade that are critical, there are 4 of them. One is that you have to have a sufficient number of functioning platelets. Next, you have to have enough enzymatic coagulation factors that allows you to form an adequate amount of thrombin throughout the clotting process. This thrombin has to have enough fibrinogen available to start forming a fibrin clot. And once the clot is formed, it needs to be stabilized, cross-linked, and not break down, which is control of hyperfibrinolysis comes into play here. Now, this is the algorithm we used in cardiac surgery. We studied it and published it in Circulation in 2016 and found it to be effective in reducing transfusions and improving hemostasis and reducing major bleeding. It's important to know that in this population, every patient gets tranexamic acid, so it's not specifically mentioned in the main part of the algorithm. So fibrinolysis is addressed by everybody getting tranexamic acid. Now, there are many different types of algorithms for different settings, so this has to be, each site has to modify their algorithms based on the patient population, their resources, and so on. In this algorithm, the point of care acids we use are Rotem and PlateletWorks. PlateletWorks measures platelet function, and that there are many platelet function monitors out there with different pros and cons. We use this one because it's easy to use clinically, and we've studied it and showed that it works. Now, as I mentioned, there are 3 components of coagulation. Well, 4 components. Fibrinolysis I mentioned, but the 3 other components are platelets, fibrinogen, and coagulation factor levels. And those are the treatment options are listed there as number 1, number 2, and number 3. And I'll come back to each of those in turn. First, I'm going to talk about tranexamic acid in various settings in terms of the latest studies that have come out. So the general comments about tranexamic acid, one is that it should be considered early if you're going to use it. In trauma, for example, less than 3 hours from time of injury is the critical juncture where it has its benefits, and potentially later than that there is potential for actually not only not having benefits but possibly increasing harm. The dose effect I've listed there, we know that 10 milligrams per kilogram IV tranexamic acid reaches a 10 milligram per liter concentration in plasma, which results in 80% inhibition of fibrinolysis. Now, it's important to note that to get 100% inhibition of fibrinolysis, you need to increase that dose by 10-fold, which is what we used to do in cardiac surgery, but that's not recommended practice anymore. And studies have used widely variable dosing without considering the pharmacokinetics of tranexamic acid, and the results have been very variable. So based on all of these things, you have to come up with an understanding of where it's indicated and how much to use, realizing that the evidence is not always great. Now, in cardiac surgery, this was a recent study that came out in 2017 and was a large multi-center study out of Australia, and it included over 4,500 patients. They used the high dose that I mentioned, 100 milligrams per kilogram, which they noted some seizures, so they dropped the dose to 50 milligrams per kilogram for most of the study. The primary outcome was 30-day mortality and thromboembolic events. What they found was that in death or thromboembolic events, their primary outcome, there was no significant improvement. However, they had a significant reduction in reoperations that was cut down by half, and blood product transfusions about a 30% reduction, which is consistent across different studies. And so it's fair to say that in cardiac surgery, tranexamic acid reduces transfusions by about a third, reduces reoperations, but in this study didn't show an effect on death or thromboembolic events. One thing to note that seizures were substantially increased in terms of odds ratio or risk ratio by about 8-fold, but the absolute incidence is pretty low. It went from 0.1% to 0.7%. So keep that in mind when you're doing a risk-benefit analysis of tranexamic acid. In postpartum hemorrhage, this study was also published in 2017, a very large study of 20,000 patients. Now, they gave 1 gram and repeated it times 1 if needed, and these were patients undergoing hysterectomy and had postpartum hemorrhage. The primary outcome was 42-day all-cause mortality, and the results, as you can see, in terms of death or hysterectomy, there was no benefit with tranexamic acid. Death with any cause, also no significant benefit, but death due to bleeding was a significant reduction, borderline. However, there was a nice signal in terms of laparotomy for bleeding with the p-value of 0.002, and there was no difference in blood product transfusions. So the laparotomy is a secondary outcome, so it's important, but it's important to note that in terms of primary outcomes, there was no significant difference with tranexamic acid. Here is a study that was just published last year in GI bleeding. So this was effects of a high-dose 24-hour infusion of tranexamic acid on death and thromboembolic events in patients who had acute GI bleeds. And they included 12,000 or so patients, and they gave 1 gram bolus plus 3 grams over 24 hours. And the primary outcome was 5-day bleeding mortality. And here also, the death due to bleeding within 5 days, the primary outcome, there was no significant improvement, and there was no difference in arterial thromboembolic events, but venous thromboembolic events was a significant increase in the tranexamic acid arm, as also an increase in seizure rates. There was no reduction in transfusions. One thing to note in here is that most of these patients had variceal bleeding or liver disease, and we know that coagulation is monitoring, and defects are very complex in liver or cirrhotic patients, and in some cases they may actually be hypercoagulable, in which case tranexamic acid might expose them to increased risk. But overall, this was a negative study that highlighted that if you use it in a population that might not benefit from it, you might show the risks of tranexamic acid. So to conclude on tranexamic acid, there is good evidence that it reduces transfusions and blood loss, particularly in cardiac surgery, orthopedic surgery, and some other areas, but it's not universal. And effects on other clinical outcomes are also not clear. We don't know if it reduces mortality or other clinical outcomes beyond reducing transfusions. No studies have really shown that conclusively. And because of those two factors, its risks may actually outweigh its benefits in some cases, so we don't recommend universal use of tranexamic acid during surgery. But if someone's bleeding significantly, then consider its use early in the course of hemorrhage. And the dosing recommendations, as I mentioned, vary widely, but I think a reasonable approach is to give a 1 gram bolus, which is about 10 milligrams per kilogram, and then repeat it hourly until the bleeding is controlled. Making sure you don't go over 50 milligrams per kilogram, beyond which the risk of seizures are increased. Moving on from tranexamic acid to platelets, I'm just going to have a couple of slides on platelets and platelet dysfunction and platelet transfusions. Now we know in cardiac surgery, platelet count drops in line with other coagulation factors. So here is a graph looking at baseline platelets after cardiac surgery. There's a 32% drop, stays low for a couple of days, but goes back to baseline before the patients leave the hospital. And the same sort of drop happens in major bleeding in other settings. Now, it's true that cardiac surgery studies haven't really shown a strong association between platelet count and bleeding. And the reason for that is platelet count, total platelet count, doesn't account for the amount of functioning platelets that are in. Now, to illustrate that, this is a study we published a few years ago now, and here I've divided the patients into low blood loss patients and high blood loss patients in cardiac surgery, and I've listed the total platelets on the left and functioning platelets on the right for both groups. In the low blood loss, as you can see, total platelets drops by about 40%. Post CPB in the blue column and the gray column. And then functional platelet is a little bit lower in each area, but you get the same sort of drop in functional platelets. In the high blood loss patients, the total platelet count is very similar, as you notice. So if you measured the effect of platelet on blood loss, you wouldn't find an effect that differentiates these two groups. However, the functional platelet, as you can see in the high blood loss group, is substantially more dropped, so that it goes from 160 to 60, which is a lot more than the ones in the low blood loss patients that dropped from about 160 to about 80, 90. So if you measure functioning platelets, you'll identify a group that is at risk of bleeding that you wouldn't have recognized with total platelet count. Not every situation leads to platelet dysfunction. Cardiac surgery is one good example where you have substantial platelet dysfunction. Other areas that we're recognizing now would be trauma, that platelet dysfunction plays a role there, and any situation where patients develop hemorrhagic shock. Once you get into shock, you seem to be getting into good amounts of platelet dysfunction. In cardiac surgery, it's not really related to shock, it's due to the cardiopulmonary bypass. And the treatment for platelet dysfunction or low platelet count and platelet dysfunction in general is platelet transfusions. DDAVP or desmopressin plays a role, but the evidence on its effectiveness is not that great, so we don't use it that much. Basically, platelet transfusions is the only intervention we have. Moving on to fibrinogen and acquired hypofibrinogenemia. I'm going to talk about the treatment options and the treatment triggers for fixing this condition. Now, just like platelets, fibrinogen levels also drop during bleeding, and this is data from cardiac surgery, and there is about a 37 or 40% drop in fibrinogen levels. And in fact, studies have shown that this is the first factor, coagulation factor, that drops to levels that need treatment. Now, we know that there is a wide normal range in fibrinogen levels. It goes anywhere from 2 to 4 grams per liter. And we used to have treatment thresholds that used to be very low, and the recommendations were less than 0.8 to 1 gram per liter. But this was based on very old small studies that are not relevant to perioperative bleeding and therefore no longer applicable. Current recommendations are to treat low fibrinogens if it drops below 1.5 to 2 grams per liter. Generally 1.5 grams per liter, but if it's severe or uncontrolled bleeding, then I would get it over 2 grams per liter. And this is based on large observational data that is more relevant to current practice. This is data from one of our studies that looked at probability of large volume bleeding, 5 or more red cell transfusions, and fibrinogen levels at post-pump in cardiac surgery. As you can see, the risk of major bleeding starts going substantially higher at about 1.5 to 2 grams per liter, which is the recommended thresholds for initiating treatment in bleeding patients. Now, to treat low fibrinogen levels, you have a couple of options. You have cryoprecipitate. We know that plasma by itself cannot raise the fibrinogen level to levels that you need. So you have to use cryoprecipitate, which is the high fibrinogen component of plasma. From cryoprecipitate, you can obviously create fibrinogen concentrates that are purified and are a substitute for cryoprecipitate. When you compare the two products, there's distinct differences between the two. I've listed some of them here. Like the advantages of fibrinogen concentrate are that it is purified and virally inactivated, so it's pathogen reduced, so theoretically the risk of viral transmission is lower. Because it's purified, you know exactly what you're getting in terms of dosage and content, whereas cryoprecipitate has various components, and the fibrinogen levels in cryoprecipitate are quite variable. Fibrinogen concentrate is easier to store and doesn't need pooling, so it's possible to keep it near the patient and treat patients faster, whereas cryoprecipitate, by the time you thaw it and pool it and give it to the patient, needs about 30 to 45 minutes. But there is questions about whether or not cryo is actually better than fibrinogen concentrate, because it also has other coagulation factors such as von Willebrand factor and factor 8 and factor 13. So there was a question about, in terms of, does the benefits of fibrinogen concentrate in terms of its pathogen reduced, being purified, etc., outweigh the potential that cryo has more coagulation factors in it. So to answer that question, we carried out this study that was published now a year and a half or so ago, looking at the effect of fibrinogen concentrate versus cryo on blood component transfusions after cardiac surgery. Now, this was a pragmatic randomized trial at 11 Canadian centers, and the question was whether in bleeding cardiac surgery patients with confirmed or suspected acquired hyperfibrinogenemia, is fibrinogen concentrate non-inferior to cryoprecipitate? The rationale being that if we show non-inferiority because of the advantages of fibrinogen concentrate, we would be switching over to fibrinogen concentrate. It was a very pragmatic study. Basically, any patient who had bleeding and had low fibrinogen level and the clinicians ordered cryo or fibrinogen concentrate, would be randomized by the blood bank after making sure that the inclusion and exclusion criteria are reviewed. They would be randomized to 4 grams of fibrinogen versus 10 units of cryoprecipitate, and then we would follow the patients in terms of transfusions and adverse outcomes. The primary outcome was the total number of allogeneic blood components administered during the first 24 hours after bypass, and this included red cells, plasma, and platelets. And the primary analysis was the ratio of the mean total units transfused fibrinogen concentrate group over the cryoprecipitate group. So a ratio of 1.0 would show that they were both having the exact same transfusions, and we selected a non-inferiority threshold of 20%, meaning that if the ratio was less than 1.2, we would say that fibrinogen is non-inferior to cryoprecipitate. The study was planned to include 1,200 patients. That would give us 90% power to illustrate non-inferiority, but we stopped the study at the interim analysis once we met the stopping rules for non-inferiority at the halfway point. So these are the study results. The baseline characteristics are listed here. We had about 370 patients in each arm, and as you can see going down, the the type of procedures were very similar between the two groups. The pump times were similar, a little bit longer in the fibrinogen group. Because these were bleeding patients who had low fibrinogen, you can see a lot of them underwent complex surgery. About 3/4 of them underwent complex surgery. These are some of the baseline characteristics. Again, very similar except for critical state before surgery. These are those patients who had serious adverse events before surgery, such as, for example, cardiac arrest post-STEMI, expanding aortic dissection, and things like that. And in this group, the incidence was higher in the fibrinogen concentrate arm than the cryoprecipitate arm. And we had defined a priori that this would be a subgroup we would analyze separately and adjust for it. These are the results of the primary outcome. So as I mentioned, the ratio of 1 means that both groups had the exact same transfusions. 1.2 in blue is our non-inferiority threshold. So if the confidence interval is below 1.2, you can conclude non-inferiority. You have the primary analysis set, per protocol analysis set, and our subgroups that we had defined a priori. As you can see, in every case, except for non-elective surgery, we met the non-inferiority threshold. It's important to note that the non-elective group are those groups that had the critically ill patients, and if you exclude those, you also note that a non-elective group meets non-inferiority. In fact, after excluding patients in critical state, you'll notice that the confidence interval is actually below 1.0. So in that group, the fibrinogen concentrate arm seems to be superior to cryoprecipitate. But at the very least, I think the study clearly shows that fibrinogen concentrate is non-inferior to cryoprecipitate. In terms of safety, there was no major differences numerically. Numbers were a little bit better in the fibrinogen concentrate group. If you look at thromboembolic adverse events, for example, it was 7% versus 9.6%, but the study wasn't powered to detect major or differences in thromboembolic events. But there was no indication that fibrinogen concentrate was associated with increased adverse events. So the study conclusions were that in bleeding cardiac surgery patients with confirmed or suspected acquired hyperfibrinogenemia, fibrinogen concentrate is non-inferior to cryoprecipitate, and given its safety and logistical advantages, it may be considered in bleeding patients in place of cryoprecipitate. Moving on to the last component of coagulation, which was low coagulation factor levels leading to low thrombin generation, needing coagulation factor replacement with plasma or PCCs. Now, in terms of coagulation factor replacement, the goal is to enhance thrombin generation. One thing to keep in mind is that there are no good assays for measuring thrombin generation. We have PT and INR, which measures initiation of thrombin, but that's only about 5% of the thrombin that's used in clot formation. The other 95% are not really measured. Clotting time that's measured with ROTEM is the same as INR in terms of when it starts, what value it gives you. And then you also have other variables such as clot formation time in ROTEM, which corresponds to thrombin generation, but is not really a measure of thrombin generation. So while we don't have a good assay, we do have, for example, if you have a patient with elevated INR, that's a good sign that coagulation factor levels have dropped to a point that thrombin generation is inhibited, and therefore there should be treatment in bleeding patients. Now this is again going back to cardiac surgery, just showing you here that prothrombin time is dropped is reduced or increased, I guess, in cardiac. So there's a change in prothrombin time in terms of percent in cardiac surgery, in line with drop in coagulation factor levels. Now this is a thrombin generation curve. As I mentioned, there is no clinical assay that measures thrombin, but there are experimental assays. This is the CAT assay that measures thrombin generation. So you've got two curves there, normal thrombin generation, and then the second curve, the shorter one, is what happens after cardiac surgery in some patients. As you can see, the peak level, that's an important measure, is substantially lower. The area under the curve, or endogenous thrombin potential time, is substantially lower in the patient that's post pump. Sorry, these are the same patient pre-pump and post-pump. So the difference, you can see there's been a substantial reduction in thrombin generation capacity post-pump compared to pre-pump. In fact, if you look at overall in cardiac surgery, here's a study where hasn't been published yet, but we have a ratio of post-thrombin generation to pre-thrombin generation. And the two things I've listed here are the peak and the ETP, which is the endogenous thrombin potential, which is the area under the curve. As you can see, on average, in both measures, there's about a more than 50% drop. And in some patients, there's almost no thrombin generation can be detected by this assay. So there is a substantial number of patients who have really low thrombin generation after cardiac surgery, and the same can happen after significant blood loss in other settings. In fact, for those whose ratio is less than 0.2, we found that there's a significant increase in need for transfusions and bleeding, and the odds ratio was 2.5-fold higher compared to the rest of the patients. Now, why is thrombin generation impaired in bleeding surgery and in bleeding patients and cardiac surgery? Well, factor 2, as I mentioned, every coagulation factor drops with bleeding and hemodilution in cardiac surgery, and factor 2 is no different. Now, we also have tissue factor pathway inhibitor that's increased, and that's because of the heparin that the patients give, and that's not reversible. And then you have the endogenous thrombin potential. Because of those two factors, there is a 50% or more decrease in ETP, and therefore patients bleed because of this. How do you enhance thrombin generation? Well, you have plasma and the cryosupernatant. Remember, cryoprecipitate is for fibrinogen, so the other components can be used for other coagulation factors. Now, cryosupernatant companies have turned that into PCCs, so I've used Octaplex as an example because that's the one we use. But PCCs are purified, and they have these factors that I've listed here, 2, 7, 9, 10, and some procoagulants, some anticoagulants, including protein CNS, and some heparin. Now, there's differences between plasma and PCC that I've listed here. Just like fibrinogen concentrate, PCCs are purified and standardized, and they're pathogen reduced. So you have those advantages. But a big advantage here is that the volume that you need for same dose effect is 80 cc's versus 1 liter of plasma, which eliminates the risk of TACO or transfusion-associated circulatory overload. The other main advantage is because it's pathogen reduced, you have no risk of trolley, and because it's purified, you know exactly what you're giving patients, and there's evidence that it may be more effective than PCCs may be more effective than plasma. Now, this is in vitro evidence looking at thrombin generation, ETP. On the left, you have plasma in cardiac surgery, and on the right, you have PCCs in cardiac surgery. Now you can see pre-pump, post-pump, there's a drop in thrombin generation on the left, and with 15 cc's per kilo of plasma, you raise that back to normal. The 1000 on the y-axis is highlighted because they're different scales. On the right, you can see that, again, pre and post, you have a drop, and with 25 units per kilo of PCC, you actually go above the baseline. So there is some evidence here that PCCs may be more potent than plasma in clinically used doses. Now there is few clinical data on the comparisons is limited. Here's an observational study meta-analysis, and that shows that transfusions are in favor of PCC. So using patients who receive PCC seem to have less need for red blood cell transfusions. One concern is safety because PCCs have more procoagulants than anticoagulants. The concern is that maybe they increase thromboembolic events, and there is to be no real evidence that that is the case. Here is a safety meta-analysis, and in various populations, including trauma, cardiac surgery, liver surgery, there was no indication that adverse events were higher with PCCs, but clearly that's a concern. So, as I mentioned, the studies are not that many, and there were no real randomized controlled trials. In preparation for a large randomized trial, we conducted this pilot trial of comparing PCC versus plasma in bleeding cardiac surgery patients. The objectives were feasibility primarily to see if we could actually conduct a big study, but we did measure several hemostatic outcomes, including whether patients needed hemostatic therapies, a number of transfusions, severe massive hemorrhage, and chest tube drainage. This was very similar to the study I mentioned earlier, comparing fibrinogen concentrate to cryo. Basically, we took any patient who was bleeding and the clinicians ordered either PCC or plasma due to coagulation factor deficiency. The exclusion criteria are listed there. Basically, we excluded anybody who might have needed PCCs because they were on Coumadin, for example. HIT was excluded because there's heparin in PCCs, and so on. Patients were randomized when the order went in, and the consent was deferred, just like our last study. And otherwise, practice was routine practice, except the sites that we included used the bleeding management algorithm that I showed you earlier. Now, the study included 2 sites. It was a pilot study, and this is the design. So patients were ordered PCC or plasma, and the blood bank would randomize them to one or the other. The lower dose of 1500 units for PCC was if they weighed less than 60 kilos, and the higher dose was more than 60 kilos, and the same for plasma, 3 or 4 units. We could repeat the dose once, but after that, everybody received plasma because you don't want to go past 50 units per kilo in PCC, which is where you probably get into the adverse event components. The results of the study in terms of hemostatic effectiveness are listed here, and we looked at multiple measures of hemostatic effectiveness. On the top you have is hemostatic therapy needed. That means once the intervention was completed, did patients need other coagulation factors? As you can see, numerically the PCC group had a better response to therapy than the FP group, but this was not statistically significant. The number of patients who had severe massive hemorrhage was also numerically lower in the PCC group, but did not reach the p-value of 0.05. Chest tube drainage was significantly lower in the PCC group, and 24-hour allogeneic blood component transfusions, including red cells, platelets, and plasma, were basically 50% lower in the PCC group. Now, the bulk of this reduction in this outcome was due to the elimination of plasma from the patients who were in the PCC arm. But even if you exclude the plasma that was included as part of the IMP, you notice that on average, the PCC group received 8.6 blood products versus 10.8 in the plasma group, and the p-value of that was 0.15. and that represents a 20% reduction. Now, as this was a pilot study, it wasn't adequately powered to detect significant differences in these clinically important outcomes. The other thing to point out is that when you look at the individual components, there was no significant difference in platelet transfusions. Looking at plasma transfusions, we essentially eliminated the use of plasma. Only a couple of patients in the PCC arm needed plasma in addition to PCC. And then there was a significant reduction in red blood cell transfusions in the PCC arm, which could be due to its greater hemostatic effectiveness, potentially, or the fact that it avoids the hemodilution that comes with plasma transfusion necessitating red cell transfusions. Adverse events, again, a very small study, but there were no signals that the risks of adverse events were higher in the PCC arm. Thromboembolic events, 7.4% versus 8.2%, and no difference in acute kidney injury or any other measures of adverse events, as I've listed there, including mechanical ventilation, duration of ICU stay, and hospitalization. So the study conclusion was that for management of bleeding due to coagulation factor deficiency during or after cardiac surgery, this pilot RCT and also previous observational studies suggest that PCC may be more effective without compromising safety, but definitive multicenter randomized trials are warranted, and the feasibility of the study procedures for such a study were confirmed by our pilot study. And in fact, recently another pilot study was published, a bit of a different design, but they also showed that it's feasible to do a large study comparing these two products. And right now we're in the process of trying to get such a study funded and hopefully started soon. In summary, therefore, the main conclusion of this talk is that pharmacologic management of intraoperative coagulopathy should be rapid and targeted, and in that way we can garner the best outcomes for our patients. Now, to institute rapid and targeted therapy, we need rapid informative coagulation assays, and I talked about point-of-care assays versus standard coagulation assays in terms of the point-of-care ones being able to give us more informative and timely measures of coagulation defects. We talked about platelet count and function, with function being particularly important in trauma and cardiac surgery. I talked about fibrinogen levels and how important it is to measure it in bleeding patients. And then we also talked about thrombin generation and the fact that we don't have any direct measures for impaired thrombin generation, but we can deduce it by measuring coagulation factor level estimates with INR and clotting time of viscoelastic assays. So once we have the diagnosis, we need to institute rapid targeted therapy. So antifibrinolytics and platelets should obviously be used where appropriate. But more importantly, you've got the issue of factor concentrates versus allogeneic blood products. And I presented data on fibrinogen concentrate versus cryoprecipitate and PCC versus plasma, going over the advantages of fibrinogen concentrate and PCC and their potential roles in bleeding patients. And with that, I'm going to stop. Thank you very much for your attention.